So, I don't know about you guys, but I'm beginning to think I'm seeing at least a light at the end of the tunnel. And you know the old joke, you hope that light's not an oncoming diesel engine. And I don't think it is. I think we're beginning to see some promise in a whole bunch of different areas. For example, I'll talk about testing, give you an update on our national testing program and the continued challenges these national programs have. Plus a potential game changer with a 5-minute coronavirus test that's already got a footprint. It's already in doctors' offices and urgent care clinics all over the country. It's not quite ready for prime time, but probably will be over the next week or two. There are also several other things that are going on. Now, does that mean you need to prepare to start heading back out? No, not at all. But it does mean that there's a lot of hope. There's a lot of potential for getting our arms around this, getting the economy kick-started again. If not kick-started, at least running on 2 cylinders rather than none, and keeping people safe at the same time. Now, if you think I've broken into the tequila or something, or smoking something, no, I'm not. I have had a couple of shots of tequila this weekend, none today. But here, let me give you a couple of suggestions on things, and we'll cover both of these more deeply next couple of days. One is the coronavirus modeling program. I believe it's out of the University of Washington. And again, Clyde will start giving you some references, and we'll start covering those over the next couple of days. And one of the things it's saying is that this is likely to peak in places like where we live, Lexington, Kentucky, over the next 2 to 4 weeks. So let's say it's May 1st. So assuming we can continue to keep transmission down during that month, and assuming that, I'm representative of baby boomers and pre-diabetics that have significant risk, and assuming that I can keep out of harm's way, then folks like me can, again, continue this decreased transmission, continue this isolation, and make it through to the next phase. And again, by that time, I think we'll have significant options for testing in both PCR, in other words, looking at the viral RNA, in other words, am I infectious, as well as what's going to rapidly become a bigger question is, do I have the antibody? In other words, am I no longer susceptible to the disease? Now that raises a whole lot of questions. If you're asking, oh, wait a minute, Brewer, you don't understand, there have been reinfections. Nobody knows that for sure, but it appears pretty clear to me and a whole bunch of other folks. If you've seen Dr. Mike and his interview of Tony Fauci, and maybe you hate both of them, but they're still both probably right about this point. There may be reinfection potential, but it does not appear to be a big risk in this space. And I'll just, again, that's one thing I know I love to withhold my opinion and focus on facts. I'm personally not worried about a significant reinfection risk after people have been able to clear the virus. So a lot of things developing quickly, better testing, treatments I think will continue to develop. But today we're going to talk about 2 things. One is risk, and significant risk associated with, one thing continues to revolve around risk, and that is diabetes, and I would say even pre-diabetes. We did a teaser on that yesterday. And let's get a little bit deeper on that. And again, a little bit later in this video, closer to the end of the feature presentation, we'll talk about a potential game changer with FDA authorization of the Abbott Labs portable 5-minute coronavirus test. So, Clyde, why don't you go ahead and show the New Orleans clip about diabetes?
For Dr. BU, actually 69 of the folks who have passed so far from COVID-19 were either diabetic or obese, which are both pretty common health conditions in Louisiana. To what degree should the average diabetic or the average person who is overweight be concerned by those numbers?
Well, I mean, I think that in general, it's a cause of concern for our population. You've been hearing a pretty consistent message from us that everybody has reason to be concerned and to take actions to protect themselves and their families from COVID-19. We unfortunately announced a death in a 17-year-old yesterday. I mean, we know that the people who are at the highest risk are the people who are in the older age group, but we also know that people with conditions like, as you're seeing, diabetes, kidney disease, and obesity are also at really high risk for bad outcomes.
Okay,
so
Claude.
That you're somebody that has those conditions. We want you to take those steps.
Thank you, Clyde. So again, just a quick repeat of what we'll be covering today: diabetes and the COVID risk. And what about prediabetes or insulin resistance? A major core message for this channel. And testing update and the potential testing breakthrough. So why is coronavirus more dangerous for diabetics? And why is it topping the underlying conditions related to the Louisiana COVID-19 deaths? Well, I don't think we know all of that quite yet, but we do know some other very interesting things about diabetes and prediabetes. And we're going to talk about that right after this slide. But just a brief update on this slide. Yep, up to 750,000 cases, give or take a few, depending on which counter you're looking at. This is the Bing counter. It's 734, and as usual, I think the Hopkins counter is a little bit higher because I think it's feeding and updating more quickly. China has continued to drop down the scale. 2 weeks ago, China was by far the epicenter. It was the big one. Italy was climbing quickly. United States has overtaken both of them. United States is by far the epicenter at this point. Italy is a declining third. They're not declining in terms of number of cases, but they're nowhere near keeping up with the U.S. And Spain is, second, and Spain is third. As you see on the curves here, the epidemic-pandemic curves, it used to look very, very different with a significant uptick with China. As China got its arms around the issue, it flattened off. And now China's not impacting the curve at all. It appears to be driven by these countries like the U.S., Italy, Spain, the U.S. and Europe, with significant inclines going on right now. Now, we've talked about heart attack and stroke as a major outcome of diabetes, and now we're looking at serious disease related to coronavirus infection, i.e., that is COVID-19. You know, COVID-19 is the name of the disease. The novel coronavirus, new coronavirus, SARS-CoV-2, all those different names are names for the virus itself. But let's go back and look at these three maps of the U.S. and we get some subtle differences, but we get a lot of correlation as well. Perhaps the biggest correlation is something that's fairly simple. Overall, you see a whole lot of dots, whether it's heart attack or stroke or coronavirus infections or COVID in the population centers. But it's not, as usual, once you start looking a little bit more subtle differences, it's not quite as simple as you might think. For example, let's look at New York. See upstate New York here? Major red spots in terms of the New York outbreak. How far it's gotten upstate New York, I don't really, it's not that clear from this. But if you look at New York in terms of stroke deaths and cardiovascular or heart disease, some significantly different numbers here. And why is that? Fewer strokes in comparison to the rest of the country than heart disease for New York. Why is that? I would guess that it's probably because of telestroke care, but it may also be due to differences in hypertension management. Bottom line, though, is that there are some slight differences. Look at California and Nevada. Again, with strokes, you see some slight differences here. A little bit higher stroke deaths in California, not so much in Nevada, whereas maybe the opposite in California and Nevada for heart disease. The COVID cases appear to reflect more the stroke, where it's higher in California right now compared to Nevada. Why am I going into all those details? Well, again, what's the underlying driver for serious risk and serious disease with all of these? Again, it's growing more and more. Question about how much is diabetes an issue here? And if you say, okay, well, diabetes is a major risk factor for serious disease, how about prediabetes? Let's jump into the discussion of prediabetes versus diabetes for just a second. This is from the CDC website talking about prediabetes. What I typically hear from patients is that my doc said I had no blood sugar problems at all, or far more often, my doc said I had, quote, a touch of sugar, so therefore I only have 1 teaspoon of sugar in my coffee in the morning rather than 2. And I cut down on my desserts a little bit. But I'm still having orange juice and oatmeal. Oh, big mistake. Think about it. And once you start studying diabetes, prediabetes, impact of carbs on your in your diet, on your blood sugar, once you start actually testing it, you start to develop a whole different set of understandings very quickly. So according to the CDC, here's one of the big questions. Well, I don't really have serious risk for a heart attack or stroke, and obviously, therefore, COVID, if I just have a touch of prediabetes, right? It's all for people that have serious diabetes with complications. Well, we have thought that for years and years and decades with heart attack and stroke. We haven't had that much time with COVID. So we don't know right now yet regarding COVID. But I would say we're just now beginning to understand the element of risk associated with prediabetes for heart attack and stroke. And my strong suspicion is that, again, it's a similar issue with COVID. And that is, it's the same disease. And in fact, if you've watched this channel, and admittedly, not as many people watch this channel as watch Dr. Mike or some of the other sensationalists. I didn't mean that. He's not totally sensationalist. It's some of the other more popular channels. Let me put it that way. Mine is admittedly very, very geeky, more of a middle-aged boomer science geek type of channel, whereas his is very different, much more for young people. But here's the thing. One thing that we're beginning to see, and you see it with, if you've watched this channel, if you've watched the comments on it, you'll see people say over and over again, I took your testing. I went ahead and got a Kraft insulin survey. I got an OGTT, and I don't have prediabetes. I've got full-blown diabetes. And my doc had said I didn't have any risk at all. Or again, as I said earlier, they just said I had a little bit of risk. It wasn't bad. My hemoglobin A1C was 5.6. So again, major unrecognized prediabetes and diabetes epidemics going on out there. Now, is prediabetes a risk? Well, let's start talking about it. The CDC site says it's clearly a risk for type 2 diabetes, heart disease, and stroke. And those of you who've begun to study cognitive decline, Alzheimer's, significant risk there. Now, let's think about something like retinopathy. You know, again, I don't have to worry about disease of my eyes, diabetic disease of my eyes until I get full-blown diabetes, right? No, it's crystal clear. Look at the science. Between 1 and 2/3 of us, by the time we get a diagnosis of full-blown diabetes, already have damage to our eyes, retinopathy. And here's just a sample. Diabetic retinopathy is the leading cause of blindness in adults in the US. About 30% of patients with newly diagnosed type 2 diabetes have some evidence of diabetic retinopathy. There are dozens and dozens and dozens of references, and they range up to 2/3. So yes, it's the same disease process, and yes, it's causing damage long before your official diagnosis of full-blown type 2 diabetes. What about neuropathy? The same thing. As you see from the American Association of Clinical Endocrinologists, prediabetes causes nerve damage. In addition to those with type 2 diabetes, patients with metabolic syndrome and prediabetes are at risk for various neuropathies, which develop as a result of oxidative stress and inflammation. So again, you don't have to be full-blown diabetic. You don't have to be carrying a card of, yes, I've got full-blown diabetes. You've got oxidative stress and damage going on in your body tissues already. Now, again, can that be causing increased risk for serious disease with coronavirus infection? I would be amazed if that's not the case. So other places about, you know, how common is prediabetes? Well, just ask your dentist how common gum disease is. And then ask your dentist what causes gum disease. If your dentist knows very much about this issue, he's going to say, well, and depending on the practice, I had actually several dentists at the recent Louisville conference, and one of them, I said, we think about half the people have in the U.S. have gingivitis, gum disease. And he was there. He said, I don't think it's anywhere near that, maybe 10 to 20% in my practice. He has a fairly high-end practice. I had another dentist that was there, and she sees folks that are with Medicaid, her state Medicaid program. And she said, mine's more like 80%, maybe 90%. So yeah, it depends, like everything else with disease processes, prevalence of disease, how common diseases are. Much bigger issue with lower socioeconomic groups, poorer people. But again, if you look at the American Academy of Periodontology, the guys that study gum disease all the time, their perspective is looking at the total number of adults across the country, 47.2% have gum disease. Why do I keep focusing on gum disease? It's very much driven by prediabetes. Again, heart disease, between 70 and 85% driven by prediabetes and diabetes. Gum disease, probably a similar number, 70 to 80% of it, maybe more, driven by prediabetes and diabetes, stroke, hypertension, and prediabetes. So why is that such a big, what's the problem here? What's the connection? Well, prediabetes not only damages nerves, not only damages the eyes, not only damages the kidneys, how does it damage all these tissues? Because it damages arteries. In fact, did you ever wonder what causes plaque? Prediabetes. Chronically elevated blood sugars damage the intima layer of the artery. Once they damage it, that oxidized LDL can leak through the endothelium, the intima, and then you get, it stops. That oxidized LDL leaks through the damaged intima, but it can't go past the media layer, the muscle layer of the artery wall. So you get these surprises all the time. You get statements like, well, my brother caught diabetes when he was in the hospital for his heart attack. Again, he was in the hospital for his heart attack. His heart attack was caused by plaque and inflammation, and the plaque and inflammation was obviously caused by unrecognized prediabetes. The CDC, is as conservative as they are, have said 1/3 of American adults have prediabetes. Until studies like the UCLA study from 2 years ago came out and said, it's probably not 1/3, it's maybe a half. And it's probably not waiting till we're 60 years old. It's starting at age 30 years old. Over half of folks in California, for example, have prediabetes or diabetes. Now, what portion of us know that? Way less than 10%. So again, those of you who've seen other videos in our channel know that we focus on this issue quite a bit. And again, major overlap between not only prediabetes and heart attack and stroke, but now again, it appears to be a similar issue with COVID-19. Clyde, if you're there and listening to me, maybe you could go back and play that that clip we played yesterday from the doctor in New York about diabetes and prediabetes with his COVID patients.
And Dr. Smith, I know in your patients today and yesterday, this week, you've seen an interesting and I guess disturbing trend of underlying conditions for those COVID patients. What are those?
I don't know if it's disturbing, it's a revelation, revealing. We're seeing a lot more diabetes than we've ever seen with any respiratory viral infection. I just did the calculation. We have 23 proven COVID patients. 13 are known diabetics. The other 9 are pre-diabetic. So only 1 out of 23 hospitalized COVID patients that we're taking care of, proven ones, is not diabetic or pre-diabetic. In the severe form, we had 15 patients with severe COVID disease in the ICU on the vent. 10 of those patients had diabetes, 4 had pre-diabetes.
Wow.
The only one who didn't was a 94-year-old man. We don't know if he had either. The testing wasn't done, and we still don't even have his COVID test back, so we're not even sure he fits that category. So the frequency of diabetes and pre-diabetes and high sugar levels when they present is enormous and something I've never seen associated with any viral infection.
Wow.
It's not really describing any of the literature I've seen so far, and I've been asking colleagues about it. For instance, influenza, while if people with diabetes should get the flu vaccine, it's not one of the main groups the CDC even recommends.
Okay, so this is Dr. Smith, this is one of the things we're going to learn a lot more about as this data keeps coming in. And I know Dr.
So thank you, Clyde. Again, those of you who've seen other videos in this channel understand a lot about our focus on diabetes and specifically pre-diabetes. With diabetes, it's been recognized that this disease process is going on. I would say that the vast majority of damage being done to the human race right now is more on the pre-diabetes side, because excuse me, so much prediabetes is unrecognized. You know, that 94-year-old gentleman that is not a recognized diabetic among his COVID patients in that last clip? I think he's got it. If you have any questions about that, read a book that we talk about quite a lot. It's called The Diabetes Epidemic and You. It's written by a fellow named Robert Kraft, K-R-A-F-T. And he basically shows, Dr. Kraft was a pathologist that ran a very large hospital laboratory in Chicago, and he was involved in doing a whole lot of what we call Kraft insulin surveys on people. And he showed those are a very definitive test for diabetes and prediabetes. And he showed that starting in the 50s and especially 60s, more and more and more of us have very significant prediabetes and or full-blown diabetes. And that trend does not stop. Each decade, it gets higher and higher. So again, what's the mechanism of damage here? Well, again, it's damaging the arteries. So which tissues get damaged? Well, the brain, #1 cause of stroke, #1 cause of dementia, #1 cause of heart disease, #1 cause of kidney disease, eye disease, gum disease, erectile dysfunction, muscles, legs, you name it. So what's the #1 cause of prediabetes then? If we get over that hump and say, okay, prediabetes is causing a major chunk of this problem, and again, perhaps even a major chunk of the damage associated with COVID, what's the #1 cause of prediabetes? Well, is it genetics? Is it obesity? Or is it just plain old getting old? Well, speaking of, I'll just do a brief diversion just a second. Many of you have heard Michael Osterholm. Dr. Osterholm is becoming very well known. #1, because he appeared on Joe Rogan Experience, but #2, because he wrote a book predicting all of this outbreak and this problem. And one of the things he said, even on the Joe Rogan Experience, was there are a series of risk factors that we worry about, that if they overlay this disease, COVID-19 infection, are going to cause bad outcomes. And if we happen to be right at ground zero for one of the major ones in this country, it's obesity. So again, we know obesity is a big issue for COVID specifically. But again, what about prediabetes? Is it genetics, obesity, aging? Here's a very typical science slide. This was by a dentist, and you see he's focusing on genetic predisposition. In other words, the genetic issues, environment, obesity. He doesn't mention aging in here. So here's my question. Why can't we see what's really obvious? Well, what is obvious? Okay, so if you look at this slide, there's several things that are going on here. #1, you've got a comparison of under age 40 and over age 40. Now, you've also got a comparison of BMI. In other words, an indicator regarding obesity. Up here, you see, we've got a comparison regarding time frame as well. So, #1, I don't think our genetics have changed dramatically between 2003, 2006, and 2011. Yet, our prevalence of disease is, our prevalence of prediabetes and diabetes. So how could that be? Well, obviously, increasing obesity could be causing that. In addition, increasing aging, but again, we've got aging factored out here. First of all, let's go back and look at aging specifically. There's no question. It doesn't matter how much you weigh. Once you get over age 40, your probability of having prediabetes is a big deal. So don't say, you know what, I'm 40, I'm 50, I'm 60, my doc says I'm okay. Get definitive testing. Start looking for this. Have a little bit of paranoia regarding the potential for prediabetes. So that's number one. We know that age is a big, big deal. What about obesity? Well, again, look at these. This versus, this is a BMI less than 30, a BMI 30 or above, and a BMI, a BMI less than 25, 25 to 30, and 30 and above. And as you can see, unmistakable trends. Yes, obesity is a major driver as well. So let's go back and focus on this one more time. Is it obesity? Is it age? Or is it genetics? Well, I think the issue is it's all three. So why are we focusing on, why are we trying to find one thing? Well, on an individual basis, I can't change my age. I can't change my genetics. The one thing I can change is my body fat mass. We're not going to get into details about how to do that, why body fat mass or obesity is a big issue. Again, we've got 700 videos out there. Probably at least half of them have to do with those topics. So I'm going to finish out on prediabetes, diabetes, and COVID-19. Again, prediabetes is a big issue for all of our health. It's the number. It's very much related and causally related to heart attacks, the number one killer in our population. And yes, we've had what, 30,000 deaths with COVID? Since that time period, how many deaths have we had from heart attack? Well, in the US alone, we have, what is it? I don't remember the number. Is it 50,000? Way more deaths. Even during the coronavirus pandemic, we've had way more deaths associated with heart attack and stroke. Oh, excuse me, deaths associated with heart attack. How about permanent disability? We've had way more permanent disability associated with stroke. So again, prediabetes has killed more people with heart attacks since coronavirus pandemic started than coronavirus. Prediabetes has disabled permanently way more people with stroke than coronavirus has. And I don't know how much, it's not clear how much permanent disability you're going to get with coronavirus. But now we're beginning to find out that it may be one of the major causes of death associated with coronavirus as well. So again, I hope that you're starting to get a message and a reorientation towards what can we do on a personal basis and a society basis. Go back and start focusing on our risk factors. Now, I mentioned that I was going to talk a little bit about coronavirus testing. The president came out, what is it, 2 weeks ago now, saying we're going to have free testing for everybody. Well, do you see a whole lot of free testing out there? I can tell you, I've been involved with now 2 different efforts to develop centralized free coronavirus testing. One of them is doing a soft launch this morning as we speak, and it has been plagued with problems ranging from politics to inability to get equipment, to inability to get test kits. We're, again, as a society, we've not been prepared for this. Now, will either of those programs continue to move ahead? I think they both will. Here's one of the things that I'm beginning to wonder, though. Are they both going to be eclipsed by much more localized testing? The FDA has authorized COVID-19 test with Abbott Labs, which already has a footprint in doctors' offices, hospitals, clinics, urgent care clinics all over the country. It's called the ID Now. You may see this right here. This little test kit is about the size of a toaster, and it's a typical thing. Groups like Abbott Labs have been setting up these little lab test programs for doctors for decades. And you use test strips, you use other things. You get the sample from the patient, you plug it into the analyzer here, and you find out the results. And it tells you things like hemoglobin A1C values, hemoglobin values, a whole range of tests. Yes, as you might expect, Abbott Lab is developing a tester for coronavirus. Now, what's interesting about this test is that it's, well, let's go through a couple of things on it. The test for the coronavirus has been approved by FDA, and it will begin production next week. They expect output of 50,000 per day, possibly starting next week. So this was like 2 or 3 days ago. So we're thinking maybe by Friday, these guys will start having significant input for, or output for this test at local doctor's offices and clinics. It's the Abbott ID Now COVID-19 test. And again, it's a laboratory in a box that's the size of a toaster. Now, interesting thing about this test, it's for RNA. It's not the antibody test. So I do expect to have antibody tests over the next few weeks available, which you can do at home, like a early home pregnancy test. And this test, which you can get in doctor's offices and ERs and urgent care centers. So I personally have a strong suspicion that these local testing options are going to quickly eclipse any of the centralized testing. Do I think that's going to happen this week? No. Do I think that the centralized testing is going to become functional this week or even next? Not so sure that it will. So again, I think on a practical basis, these localized options may become have much more of an impact than these central testing programs. So let's go back and see if we're still online, and if so, if anybody's there. Okay, yep, we've got a lot of people again. Name removed. You can change something else in your adipose tissue level than mass. When adipose tissue can be converted to light brown, yes, light brown or brown thermogenic fat tissue. Cold exposure helps do that. Some other things do as well. So thank you very much. Name removed. Adipose tissue or fat tissue is a big, big deal in this whole risk equation. Thank you for your comments. John Tucho, with the proper diet, you can impact the epigenetics. Yes, no question, John. You know, I worked with a genetics lab that focused on cardiogenetics for years, my genetics. And I don't do quite as much of that. I still have a lot of patients that are very interested, and it does help. I mean, if you know that you have significant 9p21, for example, the heart attack gene, or 4q25, for example, the stroke gene or the atrial fib gene, if you know you have those, it helps you focus on whatever risk factor and or medication and or supplement might help in these areas. But bottom line, genetics load the gun, but lifestyle pulls the trigger. We got a comment from someone here and looks like some sort of Middle Eastern script that I can't read. Thank you. More Middle Eastern script. Tom Mendenhall. What do you think about Thomas Massey? I'm sorry, Tom, you're going to have, I don't know Thomas Massey. Is it Galvin? This is our friend from Kiev, the Ukraine. Dr. Zelenko. Clyde, thanks. Referring to Gateway Pundit, I think. So, again, having a hard time tracking on some of these comments. Okay, breaking news, 699 coronavirus patients with 100% success rate using hydroxychloroquine, zinc, and Z-Pak. So yes, interesting news. I have not seen that yet. I'm not, here's the thing, I'm skeptical of any 100% success rates. I mean, even with smashing success in medicine, you hardly see 100%. I mean, we're just not built that way. There are too many variables that are important and involved with these activities. But do I expect to see significant success with hydroxychloroquine, zinc, and Z-Pak? Yeah, I do. Good morning, Doc. Rob TO7. I'm not sure how much we can trust what China says, as they were telling the WHO that human-to-human transmission was unlikely as late as January 14th. I agree, Rob, and I've said this many times. It's a little bit scary depending on what you hear from China. And one of the big questions, one of the big concerns we have is, why would China go from epicenter of the outbreak to shutdown? No question, they had a very rigorous shutdown. I mean, draconian. Everything that they do, a lot of draconian stuff over there. So, yeah, I have no suspicion that their shutdown had a big impact on transmission. What I do suspect, though, is their statements that they've opened back up and there's little to no transmission. Really? That's really hard for me to believe. Now, I will say this, though. I don't at all think that they've had a huge, I don't think they're back where they were pre-shutdown, because I don't think anybody, including the Chinese Communist Party, could actually hide that size of epidemic if it were to come back. I just don't think that's possible. So there's still some things about transmission that we don't know, and we don't have to trust the Chinese government that they're, that they've suddenly begun to be totally transparent. So let's go back down, take a look at some other comments. Obesity lowers serum levels of vitamin D. This vitamin increases the level of IL-10, interleukin 10, which is, some of the interleukins are inflammatory markers and actors. It's important to the regulation of the immune response. Absolutely. Thank you for that comment. Why is anti-inflammatory ibuprofen bad for corona? I don't think that, just like so many other things with corona, I don't think that it's crystal clear how bad, if it is bad, how bad anti-inflammatories are. I think most of that's based on the assumptions that anti-inflammatories decrease the immune response. So the immune response is needed to battle things like the COVID virus. Roscoe Tanner. Do I need to eat carbs prior to take the Kraft Insulin Survey? If so, for how many and what time limit? Yep, Roscoe, most of you will get instructions. Folks that do the test through us, for example, will get some instructions on the amount and type of carbs to eat for the 3 days prior to the test. Now, a lot of people will say, well, why do you want me to do that? I get headachy, I feel bad, I feel bloated if I start eating carbs again. Okay, I've got it. And clearly you don't have to eat carbs. Here's what, you get what you pay for. If you eat absolutely no carbs in the first carb challenge you get in weeks and months is with the Kraft Insulin Survey or the insulin survey that we're doing through Quest, then what you get is a pancreas that has had weeks or months to rest and store insulin. You see, the pancreas has two different phases of insulin response. The first phase is stored insulin, and the second phase is insulin that it makes in response to that challenge. So if you haven't challenged your pancreas at all in months, then you'll get an artificially improved insulin response, and you may mask the whole problem. So that's the purpose for it. I hope that helps. Roscoe. K. King, Dr. Brewer, niacin stops my leg pain, but I have MTHFR, hemochromatosis, and diabetes. Niacin is not good for MTHFR, and it's not good for diabetes either. So any clue why niacin stops the pain in my leg? Sorry, Kay, I don't have a clue regarding why niacin is stopping the pain in your leg. Northwest Frontier, any suggestions for further protecting oneself from aerosolization of virus in closed buildings? When I go out, I must use a hallway in either stairway or elevator without windows. You know, there was a couple of recent things coming out of the medical community specific to that. One of them was from a cardiologist who was making a fairly good case that, you know, we look in the Asian cultures, for example, and you see a lot more use. You've always seen, I mean, for decades, you've seen a lot more use of face masks, whereas the Western cultures say face masks don't do you any good. He made a case that maybe they do. Well, so would you interpret that as me saying everybody should buy a face mask? No, I think here's the problem. We're woefully inadequately supplied for face masks. Please don't take face masks away from our front lines, the healthcare workers who are dying right now because we're throwing them into battle with no armor, no protection, no inadequate protection. So the other reference I would make would be back to a recent reference by the CDC. I don't know if they've taken it down yet. I do know this is a rapidly changing area, but just a few days ago, the CDC was saying different levels of PPE, or personal protective equipment. And one level was normal, the other level I think was surge, and the third level was crisis. And under crisis, which was going on right now and has been for the past couple of weeks, they said, we fully expect people to be using homemade protection like a bandana. In other words, like Roy Rogers, you know, again, over half of the viewers here are boomers. We do have some young people too. And we've had some young people point that out. Please don't let me neglect the young people, because you guys are the guys that, number one, are even less likely to recognize your risk of diabetes and prediabetes. And number two, much more able to impact it with some minimal changes in your lifestyle. But anyhow, the boomers, the 60-year-olds, are going to recognize the name Roy Rogers and Dale Evans and Gene Autry and the Lone Ranger. Those guys used to wear a bandana. And here's what, for those of you who don't get it, this is, it's a handkerchief, and you put the handkerchief over your face like that. And the bad guys used to wear a black one. The good guys used to wear a white one. That's how you could tell who was the bad guys and the good guys. The bad guys always got shot if one of the heroes was there, and the heroes never got shot. Let me tell you, the color of their bandana and the bandana itself was not protecting them from bullets. It was the fact that they were the star of the show. In other words, it was totally artificial. And bandanas are not a great protection from this virus either. There's been a huge amount of cottage industry, heroism, a whole bunch of things helping in terms of homemade ways of dealing with this. And again, I would, whether you consider it jerry-rigged or not, I would start looking at a way to develop a homemade face mask and a way to do some sort of shield. as well. So thank you for the question in Northwest Frontier. Bill Clifford, I thought the overwhelming inflammatory effect on alveoli is what kills you, so you have to negate the body's response. Well, see, Bill, again, you're talking about two different levels, two different types. Yes, the overwhelming damage is the inflammatory response around the alveoli, the small sacs, air sacs in the lungs. Once you get to that point to where you need a ventilator, yes, they are probably going to use some very, very extreme strength steroids, as in IV steroids, not just Motrin. Now, I think your question is, will Motrin prevent that? And I don't think that's, I don't know. I'm pretty sure that nobody knows right now. And I think, again, most of that don't use non-steroidals is based on logic, not based on clinical experience. There's just not been enough time for the clinical trials for that. Erlander, Dr. B, you skipped over my question on quinine. I skip over a lot of questions. I'm not skipping questions on purpose. When you have this many people on one of these things, the questions keep auto scrolling. So you're asking me, can I go back and answer it? I've got dozens, if not hundreds of questions here, Erland. Thank you for the question, Erland, and thank you for your interest. But as I scroll back up, I'm not seeing another question from you, Erland, and there are just so many of them, I can't find them. I'm sorry. Farouk, good morning, Dr. Brewer. Good morning, Farouk. Farouk is one of our recurrent viewers, subscribers from Iran, one of the epicenters, and Farouk lost a cousin to this issue, and he warned us. One of the first warnings, at least from commenters on this channel, was from Farouk saying, look, it's killing young people too. And obviously, since then, we've found out that that's clearly the case. Good morning to you all. Robert Pinsky, off and on. Is it better to take vitamin C as a preventative if you have iron? I think that it has shown that we're seeing there's a great case to be made for vitamin C. Whether or not it works if you have iron, I don't think, I think we first got to prove the vitamin C case before you prove that about iron. I was getting ready to go reach for my vitamin C. I'm up to about 1.5 grams of vitamin C after I took a look at some of my research on vitamin C recently. Before I get too deep into vitamin C, I'll say that, yes, there's a whole host of questions where some people are saying, no, it can't be vitamin, it can't be ascorbic acid, it's got to be vitamin C. And then you have the guys that are the regular vitamin C haters and say, no, it can't be regular vitamin C, it's got to be lysosomal vitamin C. I think there's a long putt in terms of trying to prove all of that. And it isn't going to happen by the end of the coronavirus outbreak, I can tell you that. Erland, I think maybe we have found your question. I take quinine daily for leg cramps. Any possibility that this will give me protection from COVID-19? Of course, it's possible. What do I think as a doc? I wouldn't depend on it, obviously. We know what causes its exposure to the virus. So all these other things in terms of vitamin C, the other treatments, the other preventatives, even one thing in terms of what the supplements group are doing is focusing on improving the immune system function. And one of the bigger items that has had maybe more research on improving the immune system function than any of these is the BCG vaccine. And again, number one, I'm not going out somewhere to get a BCG vaccine because the risk of going out right now is not at all to me, worth the potential benefit of stimulating my my immune system. Am I taking vitamin C? Yeah, I happen to have some vitamin C in my closet. I pulled it out and started taking it again. How about zinc? Yep, a friend of mine, I was complaining about having run out of zinc, and a friend of mine gave me some zinc. Quercetin? Yep, I'm taking that too. So, Ed Herrider, please tell me, what is the, don't know, you have to finish your question. K. King, research thieves' oil used on a bandana during the Black Plague saved the thieves' lives. Well, good for them. Jackie Shaheen, please speak about healthy digestion and any supplementation. Northwest Frontier, merci, gracias, danke. Guys, oh, gosh, look at this. I have a question from my sweet wife, my bride, that appeared on this channel with me, just a few days ago. That's been one of our more popular channels. I've had to admit to her, to Janice, by the way, that to 99.999% of America, the stuff I talk about is really boring, because we talk about IL-6, IL-9. You know, again, admittedly, most of us, and there's a lot of folks tuned in, most of us are geeks. We got a lot of doctors, a lot of healthcare people, as a lot of dentists, a lot of folks. Anyhow, Janice is bringing a little bit of practical, do we have, you know, how to deal with groceries, how to deal with Amazon packages. And I keep asking Janice to appear. I think she's warming up to this a little bit more. So Janice Derrickson, quarantine may present new challenges for healthy eating behaviors with our fridges close at hand. Start testing yourself with the Freestyle Lite to collect personalized data on blood sugar levels. Absolutely. Really good point. And we got this originally from a lady named Jenny Rule, R-U-H-L. Jenny Rule runs she's a webmaster for a great diabetes and prediabetes website. It's called Diabetes 101. That's Diabetes 101. She's got a great book. It's, gosh, I don't know if it's a decade. It's at least 5 years old. It's called Blood Sugar 101. And actually, maybe her website's Blood Sugar 101, now that I think about it. But in the book, if you just spend an hour with Jenny Rule's book, Blood Sugar 101, you begin to get an understanding of how prevalent this problem is. And again, you've got tens of thousands of diabetics and pre-diabetics contributing information to that website. One of the things she said is eat to the glucometer. And now that we have an affordable continuous glucose monitoring device, we've got great options for eating to the glucometer. I've got people calling me now saying, dang, you know, for example, I'll typically, you know, I mentioned those patients earlier on that would come in and they say, Doc, you're not going to tell me to quit eating, to quit having orange juice, cereal, and or oatmeal for breakfast, because I know oatmeal specifically is very, very healthy for you. And then we get them hooked up with a Freestyle Libre. It's that little plastic button. I don't have mine on because I ran out of them before COVID-19 and have not replenished. What they start finding, they come back to me and they say, oh my goodness, I had no idea. Then they find out other things too. They find out, gosh, I know I have this problem, and I will occasionally be bad and take, you know, I'll take a carb vacation. The health coaches in this world, like Janice, don't like to say somebody was bad or they fell off the wagon. They just say, look, I took a carb vacation. And then I find out I can go out and take a gentle walk for 20 minutes, half an hour, and I just cut the top right off of that spike. I do not have a spike if I just do a gentle walk after dinner. So you begin to learn a whole lot if you just take the time to look at your blood sugar. Great comment, Janice. Thank you for your contribution. No trash in heaven. $10. Not sure at all what that means. You know, I'm beginning to wonder. I know no trash in heaven, is that like a $10 contribution to the program? If it is, thank you very much. And even more so, you would be the very first who's done that. There's this program, and I forgot what you call it. I've seen comments about it where people can make little contributions while they're, and this is not a little one, $10 is a big deal. It can help us in terms of getting that information out there. So, No Trash in Heaven says, I'm getting a deeper and well-rounded education. Thanks, Dr. B. Well, thank you, No Trash in Heaven. Kelly Clover, recent cardiac calcium score test said it found a perivisual nodule. Not sure that I've heard of perivisual. On the right middle lobe, is there any possibility this could be from COVID-19? I'm sick and tried unsuccessfully to get tests. It depends on where you are, Kelly. I have to tell you, and I can't tell you it's impossible, but just given my background, I'd be very surprised that that anybody's already getting significant calcifications from COVID. I just started NAC. I'm salty and lit. I just started NAC yesterday. Is it normal to have some tummy discomfort? A lot of supplements, especially high dose vitamin C, but also N-acetylcysteine, garlic, some of the others as well can cause some gastrointestinal inflammation. One other thing, I will tell you this. I don't know if anybody's noticed, under appearances and cosmetics, you might notice I'm not as shaggy as I was before. Janice took me out in the backyard and cut my hair last night. So thank you again, Janice, for all that you've been doing. K. King, what is that eat to the glucometer? How do we get it? We can get you set up with continuous glucose monitoring with Freestyle Libre. We can also get you set up with the Dexcom 6. Unless you have full-blown, significant, way beyond question diabetes, most insurance companies aren't going to pay for them. You have to pay for those yourself. But you've got a $20 to $50 solution. You just go to and you don't need a prescription for it. You just go to your local drugstore and get a glucometer, finger stick glucometer. J. Markham. And K. King, if that's not clear enough for you, just watch a few of our other videos. Just look up Freestyle Libre, Ford Brewer, YouTube. Jay Markham, thank you for your presentation. Good job. Thank you very much, Jay. I appreciate that. What's the highest zinc dosage we can safely take? I don't know. I do know that I'm taking 50 per day right now. Kevin's back. Dr. McCord, great preventive medicine doc just south of Cincinnati. Using a CGM, continuous glucose monitoring system, has been a revelation in managing my own metabolic health. I highly recommend it, especially for healthcare providers. You know, it's so interesting, Kevin. Thank you for, here's a doc talking about this. And guess what? I felt the same way when I finally got access to Freestyle Libre. For decades, we've been flying blind. We've got significant risk with our blood sugars going high, and we've been ignoring it. So go out there, start checking, eat to the glucometer, exercise to the glucometer, manage your lifestyle to the glucometer, start looking at a dashboard. Test, don't guess. So this is Kelly King, research magnesium. Magnesium does appear to have some significant positive impact, especially for people like me that have atrial fib. And guess what? Just like prediabetes, a lot more of us. If you think you don't have atrial fib, you might be right. But a lot more of us have atrial fib. Atrial fibrillation, it's by far the most common um, cardiac dysrhythmia. And yes, for the most part, it tends to be asymptomatic as well. And yes, it's associated, very much linked with heart attack. It's a major stroke risk. It multiplies your risk of stroke by about 5 times. And it's very much related to diabetes and all of these, this constellation of chronic disease. No trash in heaven. The donation button is on the right side of the public chat bar. Well, thank you again, Trash in Heaven. And let me just read that again for those of you who have an interest. Again, as for me, this is my 3rd retirement. I've been involved as a medical director for a lot of companies, and financially I'm fine. But here's the problem. It does take significant money. We've got to, depends on who you're counting and how often you count and what your most recent count is. We've got about half a dozen full-time folks. Most of those are offshored. We've got two full-time folks here in the US. One of them is me, and I'm not getting paid, but the other one is. So in order to get this information out there, it takes money. And No Trash in Heaven, thank you again for making that contribution and for telling other folks how to do it. If you want to know how to do it on the short term, just the donation button is on the right side of that public chat bar. And there are other ways too. We have a, I can't remember what you call that, that thing that you can do a monthly thing. We've got an account there if you'd like to go into that. It's called, what do you call that? Maybe I'll remember it. Another senior moment. Okay, Bart Robinson, thanks again for the daily update. Thank you for the recognition, Bart. It started wearing on me heavily, especially after the testing program started to, the grade shift and part of it blew up. I started feeling like, dang, all of that work for nothing. That's not true. I'm actually doing work with both sides now. Is it for nothing? No, it's not for nothing. And again, we don't have 100,000 people looking at this, but we clearly have thousands of folks that are seeing this as worth their while. Can you reiterate, does the virus prefer cold and humidity or cold, dry conditions? Thanks again. I wish I remembered that. I did read up on it, Northwest Frontier, recently. Forgot. And here's the thing. You're finding it on surfaces days after, and weeks after it was deposited. So, you know, you have to get back to some of the basics on this. Number one, it's a wimpy virus. It doesn't last that long in significant conditions. Very weak hypochlorous acid knocks it out. But you'll hear some people say viruses aren't even alive. Other people will say viruses are alive. Here's the people that say viruses aren't alive, and here's why that's an issue. Viruses don't ingest food. They don't breathe. They don't create. They don't have cell wastes. They're not even a cell. A virus is just a protein and glycoprotein shell with an RNA enzyme / hypodermic. It latches onto the cell membrane. With COVID-19, we know that it's with the ACE2 receptor. And then it injects that RNA into the human cell. It hijacks our genetic material mechanisms. So we're not making our own DNA anymore. It uses it hijacks an enzyme called RNA-dependent RNA polymerase. Easy for me to say, huh? And that's where some of the other things come in. This thing about zinc. Zinc slows down that RNA polymerase. And what about quercetin? Quercetin is a it is what's called an iontophore. It helps get zinc in through the cell wall, because zinc is an ion, and the cell wall is mostly cholesterol. So quercetin and guess what? Chloroquine and hydroxychloroquine all look very similar, all have some of that chicken wire molecular structure, which helps them get into the cell wall and helps them pull zinc into the cell. So zinc can help shut down that overuse of RNA, dependent RNA polymerase. Now you got to ask the question, why did I go down that bunny hole and then from that bunny hole to the next and the next and the next? Here's the thing. You ask the question, the virus and how long it lasts. It lasts days and even weeks on surfaces. And here's why. Because it's not a full-blown active cell with a lot of requirements. It's just a hypodermic, a biological hypodermic sitting there waiting for you to touch it. So maybe I answered some of your question, maybe not. 147 degrees west from Alaska. Thank you very much for your interest. Could you talk a bit about your efforts in getting tests out? We still have extremely limited testing here in Alaska. So one of the issues is PPE. You know, if you're going to have people putting something up somebody's nose, a swab up somebody's nose, you got to put them in PPE, especially when they're going to be seeing hundreds of people a day, many of which are going to have coronavirus, and they're going to be sneezing that out on folks. Well, as you see, we don't have enough gowns. We don't have enough gloves. We don't have enough N95 masks. We don't have enough face shields. We don't have any of that. So again, as you see with the CDC comments before, we're asking people to volunteer and go out and do that. We're not asking anybody to do that with a bandana, but clearly with this kind of virus and aerosolized transmission, you should have a negative pressure room, which sucks the air out through filters, and a positive pressure air source for the person who's doing the testing. Nobody's got that. I mean, well, I have actually seen a few pictures where that's going on. I think it was in South Korea, but that's not happening in the US. So that's item number one, PPE. What's item number two? Well, item number two is you got to have a test kit. That is the biggest issue. And people have complained about the CDC. I have to admit I have too. Bottom line is the CDC is the Centers for Disease Control and Prevention. Obviously, this disease has not been prevented very well. And the CDC is also responsible for the test kits for any new disease that's coming through like this. And perhaps the biggest challenge, beyond PPE, beyond test kit, beyond the swabs and the test sampling kits, is the test kits itself, the ability for labs to bring in a sample and actually test it. Just not available. We kept hearing from we still do have a national lab associated with it, and they said 3 weeks ago, we're going to have tens of thousands a day starting at this point today, and they're not available. So just way too little test kits available. So what's another, biggest problems? So here's another problem. Ours is not the only mass testing program that's struggling right now. Multiples have already started and crashed. Why did they crash? Well, here's the reason. You've got a lot of focus on this disease right now. If you open up a portal or a website to say, yes, we're going to take these, we're going to do mass testing, you got to be ready to get tens of thousands of calls and requests for this test. So Thank you, Bill Clifford, by the way. Bill Clifford just did a 1999 donation. Again, thank you so much. You're helping us get this information out. So back to 147 degrees west and their and the problems with the testing. So biggest issue is lack of the lab test kits. Then you have lack of swab, the swab sample testing. Then you have lack of PPE. Then you get political stuff where, again, whether it's partisan politics or local politics or state politics, everybody's got enemies. That's just the nature of the beast. And everybody wants to get out in front and start saying, we did this, we did that, we're working, and we're providing stuff. And meanwhile, constituents are wanting to say, look, you're not doing this for me, you're not doing that for me. So you get a lot of political pressure. Folks are overreacting and sometimes being a little bit too competitive. Major issue. Our Sunday school class just studied Tower of Babel yesterday, and it was like so reminiscent of the Tower of Babel. People talking different languages, all with different goals, wanting to maybe more concerned about what their team accomplished than what actually got contributed. Again, very typical. You see it all the time. Now, I was talking about the portals crashing. Again, another concern about the way the CDC developed the testing program. So the CDC, if you go back, and I've done a couple of videos on this, go back and look at my own video. I think it's titled CDC Testing Criteria. I've done 2 or 3 and actually even caused consternation within our own group, our management group, because it wasn't clear. And I've been saying to these teams, the national testing teams, look, the CDC criteria are not clear, and they're not. So here's what the CDC criteria are. And when you start saying, wait a minute, that's not clear. Exactly, that's the point. They're not clear. And why are they not clear? Because the CDC guys that wrote this knew that there are not going to be test kits available. So they're trying to redirect anybody asking for a test kit for a test back to practical considerations for managing the disease without a test. In other words, here's the criteria. Number 1, if you are if you're somebody that went into the hospital with COVID-19, well, yes, of course that's going to be done, but that's going to be managed by the hospital. Number 2, if you're someone who is caring for someone in the hospital with COVID-19, well, of course that's obvious, but those are also going to be handled by the hospital as well. So then there are groups out of that are real and would show up at a public testing site. Those groups would be, for example, EMTs or first responders who were helping care for someone with a proven case. So those folks would show up. But then what's the third criteria the CDC sets up? Well, are you over age 60? Do you have fever? Do you have a cough? Once you start getting into that kind of logic, then these, quote, public portals that are going to need to withstand tens of thousands of hits immediately are just blowing up. So 147 degrees west, you look at all of that, you say, well, Brewer, you went into too much detail. Here's the simplicity. There were no tests available. There's still not enough tests available. And it's those unethical, sometimes they're called a Persian or Middle East rug market, where sometimes you have prices and things going off and on. That's what you've got going on right now, not only with PPE, but also test kits. Bottom line, simple issue for these testing programs is the test kits. Robert Pinsky, I'm going to take a couple more and then we're getting kind of long in the tooth here. I used the Freestyle Libre and found out that I didn't have big spikes, but my average glucose is too high, around 105. My highest spike is around 130. I've been doing low carb for years. Thank you for sharing that, Robert. And I would say, I wish all these people that are actually spending a lot of hour after hour after hour at 130, 150, 180, 200, 250 knew what you know. Because I've got plenty of people that are full-blown diabetic. They didn't know it. They found it out with me. By using lifestyle, they're managing their blood sugars to rarely go over 100 or 120. So this is not, none of these problems are problems that we cannot fix. That's part of the, even with COVID-19, I'm seeing the light at the end of the tunnel. I don't think that's an oncoming locomotive. We just need to calm down, think about what we're doing, and do what's right. That's probably a great place to end. Thank you very much for your interest, for your comments, and thank you so much for No Trash in Heaven, and I think it was Bill Clifford for the contributions. Those were great. Oh my gosh, now we've got Warren Thorpe as well. So thanks guys very much for your contribution. It will, all of these contributions and then a whole bunch more, obviously, is going back to pay for this channel to get this information out to folks. Thank you.